setting. So in clinical setting, when you come, we do simulation-based learning. We do that. We have eye fidelity mannequins and virtual simulations. It's very different what you learn in the academic versus what you're going to learn in the simulation lab. We do debrief, pre-brief before we do the simulation. As I said before, I train new graduate nurses and we hire them 3 times a year. So our cohorts are for February, July and October. So we get a set of new graduates and we put them in a lot of training. And one thing that they have to do is a simulation. It can be a sepsis or PE simulation. We give them the pre-debrief and then we ask them, okay, here it is, go ahead and do it. And we evaluate. A lot of times what I've seen is many times the new graduate nurses have a lot of deficiencies. We give a scenario, there is a live patient and the patient is talking, we want them to do the assessment, even though we went over with the assessment, everything, but when it comes to a live patient, things are different. And if the patient, you're doing assessment in between, the patient says, hey, I have pain, I need pain medication, it just throws off the nurse because you're not prepared for that. And you're calling the doctor, and the doctor hangs up, giving you an order, and you didn't have time to get a read back. It challenges you, and you're not prepared for that. You don't know how to handle the situation. So we do a lot of simulation-based learning, which truly mimics the actual bedside. And this is safe environment. We tell the new graduates, this is totally safe environment. You are allowed to make mistakes and you make mistakes, and that's completely okay because that's how we are going to learn. So we're not expecting a perfect, skill that you have to demonstrate. It also improves clinical judgment and clinical competence because we do a very good debriefing after the simulation-based learning. And the debriefing always enhances reflective learning, which we are going to see, which is another strategy. Strategy 2 would be clinical rotations. For you in the academic setting would be clinical rotations. For a new graduate nurse that's going to work in the healthcare setting, we call that as a clinical orientation. Now, clinical orientation is very, very important. Now, if you're getting 1 week to 2 weeks of clinical orientation, that's okay for an experienced nurse. You get a new hire orientation, and then clinical side, you might get 2 weeks or 3 weeks. That's, again, fine for an experienced nurse because they are up and running. But as far as a new graduate nurse, this is not okay. You need a lot of time with a preceptor. All our preceptors are trained. They go for 8-hour training on how to precept a new graduate because not every experienced nurse knows how to teach at the bedside, how to train at the bedside, how to communicate at the bedside. So we do extensive teaching to our preceptors where they have to take 8-hour class, and then they have to take the renewal class every 2 years. And also if they are going to clinical, for example, if they're coming to ICU, I give them an additional 1-hour training because ICU is different. So it's specialty based training. And then this clinical rotation is important because it integrates classroom learning with clinical practice. This is the most effective premises of nursing environment for clinical learning is that it's supportive, it's free from fear, and encourages openness and respect for the learner as an individual. During this time, you have hands-on, which gives you more exposure to the nursing practice. Case-based learning is another strategy. This is realistic patient scenarios for analysis, promotes critical thinking, clinical reasoning, encourages collaborative learning. Case-based learning helps students think like nurses. When I say student, I mean the learner. It can be a new graduate, or it can be a nursing student. The key attributes of this is it facilitates learner reflective learning and implementation processes that meets learners' preference. You need to have acquire. So just know when it comes to nursing, when it comes to clinical competence, it's all acquired, meaning you learn it and you develop the skill. We're not born with the skills. You can acquire all of those things. Um, Case reviews are done in a clinical setting, which is very, very helpful. For example, I would say, let's say we have a patient that fell, or a patient had a catheter associated infection. So a case-based learning is going retrospectively and looking at the particular case and trying to figure out how could we prevent that from happening again, or what are the things that went. Is that just culture that we want to follow? Is there an educational need that the nurse has, or is it a doctor that probably did not do what he's supposed to do? So we look, the case-based learning is very nice for certain situations because you really learn the process, you really see the big picture. It really helps in critical thinking and clinical reasoning. And it encourages collaborative learning too, because when you do a case study, case-based learning, you are not with you're not reading the case by yourself or with another person. You have a group of team. You have an interdisciplinary team that actually goes over, and each person is an expertise in their own field. So you all come together and contribute and learn together. The fourth strategy is skills lab and written demonstration. All these strategies, just know, again, we are talking about these strategies to close the gap, because you might have great knowledge, you might have passed all your semesters 90% or even 100%, but all that knowledge, you will be only successful at the bedside if you know how to translate it. And that's where we come in as nursing specialists, where we really teach you and train you the way you need to work. Skills lab and written demonstration, it's hands-on practice of technical procedures. Checklist ensure competency, supports learners' confidence and safety. For example, um, you you are taking care of a patient needs an IV access. You worked you worked in college how to insert an IV using a mannequin, but on a real patient, it's different. It takes several tries for you to get the IV. Sometimes, if you're lucky, you get it on one stick or two sticks. Sometimes, patients have their veins are like thread. So how do you get an IV access successfully? And what is the right way? What is the technique? Do you remember all the steps to get an IV? Like, do you remember like all by heart? Maybe not. So here, what we do is we have access for MOSBYs. Any nurse wants to do a skill, they can access everywhere. We have workstations, and our charting is Epic. It's computerized electronic health records. So anytime a nurse wants to know about a procedure, maybe the supplies, or wants to see a video, they can quickly go to the workstation, access the intranet, type in MOSBY, and then type in the skill that they want, and they can get everything that they need. Quick sheet in MOSBYs would print just the steps that you need to do, like right then and there. Extensive education is also there. If you want to learn more later, you can print and take it, or you can just read it in the system. Supplies or videos, whatever it is, we have that kind of access. The other thing is as a preceptor, experienced nurse will check you off because we want to make sure you know and you know how to do things. And that's a checklist. When the preceptor will make sure you follow the steps that you do and will check you off using the checklist. When you're checked off, now you become competent in that particular skill or a task or a procedure. Again, skills written demonstration is usually done on the job, at the bedside with the preceptors. Sometimes the written demonstration, center line dressing change, it might take 4 times for you to get that skill. Taking a blood draw, doing a blood draw might take another 3 times for you to get that skill. So written demonstrations are great because that will improve your confidence. And not only that, it is all about competency. Next one is role playing and communication practice. I teach a lot of critical care classes. I train nurses on written demonstration. I do in-services. I show them how to work with the machines and stuff like that. Again, when I do it for experienced nurses as well as new nurses, newly licensed nurses. Now, newly licensed nurse might need a little bit more time, and I might have to spend more time with that nurse compared to an experienced nurse. Now, role playing, let's say I'm taking a class and there is a difficult patient, and you want to witness a consent, and I want that to role play. I will call my nursing new grads and say, hey, do you want to all right, let's 2 of you come and let's do that conversation. Let's see how you do it. Or I can be the patient and I will ask them, okay, talk to me, tell me what I need to do, or just educate me, or go over the teaching, anything. So I would ask them to role play. A lot of times what I've seen is when I ask them, they're not comfortable. They will say, yeah, I know, we witness a consent, so we will get the translator, we will do this, we will do that. Everything is great verbally, but if you really ask them to do, there are a lot of struggles. They don't know. If a patient refuses, what would you do? Oh, I'm going to give education. Okay, go ahead and give me that education. Then if you put them in the spot, they don't know what to do. And that's exactly what happens at the bedside. Because you're not going to have the best patients. You're not going to have really nice patients. Patients are very vulnerable. They're already suffering. They are very ill. And you have family that's already stressed. And you should know how to talk to the families. And if your family is asking questions, if you don't know the answer, you should know how to handle it. So role playing will definitely help in the communication. It does build interpersonal skills. And you all know that communication is a key to quality care. I have great nurses that are new. I've done orientation for them. I put them in with preceptors. And sometimes I get complaints or concern from the preceptor because the nurse does all the tasks beautifully, but doesn't know how to communicate or is not very assertive. So that is not good because here it's nurses call the shots. Like it's the nurse that's at the bedside. It's a nurse that does the assessment. It's a nurse that sees what's wrong with the patient and makes a call to the doctor who's not seeing the patient and gives all the assessment and also gives a recommendation. We follow the SBAR. And if we say, hey, I think he has a fever and he has all the symptoms of SIRS and looks like he's in sepsis, do you want me to do that screen? Like, I'm the person that's giving that information to the doctor because the doctor is not there and the doctor is not laying eyes on the patient. But if I don't know how to do that, Or if I mislead the doctor in a PE, pulmonary embolism, or a MI, or something else, then the whole interventions might go totally different. So your assessment is key. Your communication should be crisp and clear. Concept mapping is also a good strategy to use at the bedside or for teaching, especially for nursing practice. It's a visual tool linking assessment to intervention. It supports clinical reasoning. It does help organize complex information. A classic example would be, let's say I have a or you have a post-operative patient. It's a surgical patient. The patient came from the uh, or after a 4-hour surgery, and you are taking care of that patient. So now the concept mapping is really understanding what is going on with the patient. So patient might had a problem, went through the surgery, might be risk for more complications and bleeding. Patient's vital signs have to be stable. You have to look at the labs. If the labs are abnormal, if the patient is hypotensive, and this patient, you're addressing the pain, you're also thinking about the DVT, and so forth. So there is so much more that's going on with the patients that you're linking everything. You're trying to process that complex information, and you're coming out with good clinical reasoning, and you're making good clinical judgment. So concept mapping is a good strategy as well. Reflective journaling. Reflective journaling is important. You know why? Because as a nurse, we're always, if you're a new nurse, just now you're really task oriented. If someone says, I know how to critically think, then you're wrong. And I do not agree with most of you. Not everybody is critically thinking when you're a new nurse. Sometimes you're so task oriented and you don't pause and you don't think, and that's where the reflective journaling comes. It encourages self-awareness and insight. It fosters critical reflection on clinical experience. It does support lifelong learning and emotional intelligence. Emotional intelligence is very important. Now that's like a hot topic, whether you're a leader, nurse leader, whether you're a director or a CNO, or whatever levels of leadership, or even at the nurses level. Emotional intelligence is a must, and you need to have an IQ that where you're aware of your emotions and you know how to control your emotions. So in reflective journaling, because we don't pause, right? As nurses, we are always multitasking. I tell this to all my new graduate nurses when I sit with them, when I debrief with them. If you are with your preceptor, experienced nurse, the first day, your observation skills are extremely important. When you go on your first day with the preceptor is going to teach you something. The second day, you learn something. And third day, you probably learned how to give a medication. And you're so excited and you want to prove to the preceptor that you want to give the medication. And you would do it, which is nice. But the thing is, you're focused on giving medication, but your preceptor is going to each room and taking care of other stuff, which is very important for you as a new nurse. You have to be hip to hip, and we call that as a married state. So in married state, you're hip to hip with your preceptor, meaning wherever your preceptor goes, you go with the preceptor. The only place that you don't go is the restroom. Even when they're taking a break, you take a break along with your preceptor. So that's what we say during clinical orientation. There is a point that you can be comfortable and you don't have to be hip to hip anymore, because there are different phases. I'm going to show you the reflective journal that we use here. So this is an example where our new nurses use the reflective journaling. So they have to do every week. They write their name, they will share their challenges. It's got some questions that they have to answer, which is neat because end of the day, or not end of the day, end of the week, they need to submit this to us, and we read this, we go through this. If we see something, we will talk about it, which really helps them keep a tab on things that they have seen and also helps them feel accomplished. Eighth strategy is team-based learning, structured group work with peer accountability, improves communication and collaboration, enhances engagement and knowledge retention. So team-based learning fosters team skills and shared problem solving. Studies have shown that team-based learning has a high impact on clinical preparedness. So it's just like you're not alone. In nursing, you're never alone. You are always with someone else who's more experienced than you. You have a charge nurse, you have mentors, you have all kinds of resources. You just need to know when to ask for the resources. And if you're new, you never assume things. It's always better to have another set of eyes to validate whatever you're doing, especially your assessment, or if something is abnormal, just get another person and let them validate, and they might be able to guide you. And I will say why when I really take you to that journey. Evidence-based practice and quality improvement projects. This is something that we do for our residents. One of the things that, it's a big push everywhere, is not having enough evidence-based interventions. But in my facility, the healthcare that I work is really a large healthcare facility. We're all about evidence, and we literally have a shared governance council, and our residents, new graduates, will have to do a project. They don't have a choice. It's part of our PTAB, which I will tell you what it is, but they have to do a project, and I guide them with the project. And I had several projects that are really, really successful, and they had made a big impact. They also have to present during their project during their pinning ceremony, which is after a year. So in evidence-based practice, application of current evidence into practice, you're having that spirit of inquiry, and you also come up with innovative solutions. This is important for care delivery, patient-centered care, which is more towards safe and quality care. We went away from volume-based to quality-based care now. So transition to practice, we have programs, and that's what I'm going to talk about maybe in a couple of slides later, are aligned with the American Nurses Credentialing Center. Now, you might have something different, which is your professional organization or nursing council. So here, this is an accredited program. Just like a hospital gets accreditation at different levels, a nurse residency program gets accredited, and they are measured on different things, and they want to make sure that we do a good job in acclimating our new nurses to the healthcare setting. So it is designed to promote and support the nurses. It does improve retention, and it reduces attrition. Projects help to see the value of evidence. You get to ask questions, and also you get to find the solutions that are evidence-based, and you get to implement that. And this is our nursing process for EBP. If you're a new nurse, you identify what is EBP. We teach you. It's an 8-hour day, which we made that into 2 days. We kind of go over what is evidence-based practice. We let you do critical appraisal. We let you search. You come up, you work on the floor for some time, and then we ask you questions like, hey, what did you see? Is there something that was really stupid on the unit, or something that was not some kind of practice that's very inconsistent? do you think we need any improvement on anything? So we ask all those questions, and they get to come up with a problem of their choice, or we might be having some issues with pressure ulcers or whatever. We can sometimes, if they have a hard time, we give them a problem. So they need to formulate a PICO question. They have to search the evidence. They have to critically appraise the evidence. They have to present their problem with the PICO question to us. And once we approve that, then they get to implement the change. The intervention is definitely have to be evidence based. They do the evaluate the outcome, and they disseminate the results. This is done during the pinning ceremony, and they also do the next steps on sustaining the change. So those are the practical changes, practical strategies. Now I'm going to show you how to put all of this into practice for a new nurse, or how do we really apply this, right? All these different methods, these are great methods, but how do we incorporate this into our residency? How can we use all of this or utilize based on the needs of the learner at the bedside? So that is practice to transition. I want you to understand the terms. Hopefully the time. I want you to understand the term nurse resident, nurse fellow. A nurse resident is a newly licensed nurse. In your case, it would be a new graduate. A nurse fellow is someone, usually they have experience 6 months to 1 year. But a nurse fellow is someone that's working in a medical surgical unit, wants to go to a different specialty, then they have to go through the residency. Because it's a different specialty, you're a novice, you don't know. Whatever experience, I can have 10 years of experience. I worked in ICU. If I want to go to L&D, I'm a novice. I don't know anything about L&D. So I start over from the beginning, like a new nurse. So that's nurse fellow. And anyone that goes through a structured program for a year, that's called nurse residency program. As a new nurse, you might be, once you're graduating, you go to a facility, you might be new to the role, you will have some self-doubt, you have anxiety, stress, and lack of theory knowledge and lack of clinical exposure. All of this is going to contribute to that knowledge practice gap. And attrition means employees leaving due to resignation, retirement, or voluntary reasons, or layoffs or terminations or job elimination. It can be anything. So attrition is just employees leaving the facility. So in the United States, we have about 30 to 50% attrition that is reported. So that's not good. So theoretical framework that we use is Patricia Benner. There is a novice to expert level. According to her, nurses progress from a novice to expert. I'm not going to read this, but you guys should know the theoretical framework. I'm going to skip this and take you to the 5 stages. So if you're a novice, you're a student or a new grad. If you're an advanced beginner, you're less than 1 year experience. If you're competent, and that's where we want every single nurse that's working at the bedside, we want them to be competent, meaning they should be able to provide it's a prudent nurse that's able to provide the care that's supposed to provide for a patient, and that is standard of care. A nurse will be competent in 1 to 2 years, proficient is 2 to 4 years of experience. An expert is someone that has 4 years plus is considered an expert, according to Patricia Benner. Now, this is very important. Now, whatever I'm sharing what I am familiar with, but there are other models that are utilized by different healthcare, different organizations. But I'm just going to share you what we use, which is really neat. You will understand what it is. We use something called New Tiered Skills Acquisition Model. We call that as a TSAM. We use this model for orienting the RN residents. Again, resident it means a new nurse, a graduate nurse. So it's an evidence-based model that was developed by an NAPD specialist, a nursing education professional development specialist at Mayo Clinic, and they found that the nurses were very happy end of the orientation. They stayed with the organization, and it really worked. So why do you see a car here? Because this model mimics or kind of presented as a car analogy. I don't know how many of you know driving, but here everybody drives. So it's driving, it's like driving a car. So if you're driving for the first time, you take driving lessons. When you go to the I don't know, to a place where you get the lessons, there are certain things that they're going to teach you. They're going to teach you about the safety features. They will teach you like how to hold the steering, where is the brake, how to press the accelerator, look at the dashboard, make sure the fuel is there, put on your seatbelt. So there's so many things that you have to do. All those checks you have to do before you get to drive, right? So this is what you learn in a driving lesson. You learn all of those things, and then slowly you start driving, and then you take a test. You learn about the rules and regulations about the driving. Now, this model, our nursing orientation model, is something like that, meaning if you are a new nurse, we are going to teach you how to give a medication, how to titrate a medication, what are the medications that requires double signature, dual sign off, or what is a controlled substance? Can you throw the control? There are rules, there are policies, there are standard operating procedures at the bedside. You don't come and do whatever you want. There is a hard stop on everything. There are steps involved in everything. There is a competency for every skill that is attached to the patient, right? So when you're a new nurse, you're learning with your preceptor, you're learning all of those things. And when you are doing that independent practice, meaning your preceptor says you're ready to work by yourself, and then you are working and you're taking care of a patient assignment, you are like driving the car for the first time because you're so task oriented. You will be like, okay, oh, I learned this. Oh, I have to give the medication. Oh, I have to pull so this is how I program the pump, right? So whatever you're learning, you try to put that, practice that, just like driving a car for the first time or in the initial phase. So it takes for you to, you do that everything. You're so task oriented, and every time you're like, okay, oh God, I need to do the assessment. I need to give the medication. I got to get the patient prepped for the procedure. Oh, the family is here. I need to look at the labs. I have to get the blood sugar checks. So you're so task oriented in the beginning. And that's exactly what new drivers would do in the beginning, right? But as you keep driving for a long time and you get that experience and when you get comfortable with that, now I've been driving for a long time. If I go sit in the car, I don't even think about it. I just put the seatbelt on, start the engine and drive the car. And that's muscle memory. I don't stop and say, hey, wait a minute, am I looking at the dashboard? No, you don't do that. It's a muscle memory. You go sit and you automatically drive. And that is muscle memory, which you will get with the nursing practice on medication administration, doing an admission, doing a discharge, doing a transfer, giving all those nursing tasks, whether it's assessment, bath, or carrying out orders. It takes muscle memory. You do it every single time, every single patient, every single shift. It really, what you do is you develop that muscle memory. And then at one point, what's going to happen is you just go and do it. Like it's no big deal. And this model mimics that. And sometimes, why is it so important? Because this model, when I say tiered skills model, the way the orientation is first time when the nurse is on the unit, all they do is shadow the preceptor. The second day when they are there, they get to do the basic stuff like checking vital signs. The third week is when they start giving medication. The fourth week is when they start titrating the medication. So it's every time, every week, they get few skills and they master the skills. So we have these skills. We kind of they progress from one skill to another skill to another skill to the most complex one later. So it gives a lot of time for you to get acclimated at the bedside. And what if, and if you, nursing is all about unpredictable environment, right? You cannot predict the shift, you cannot predict your patient. You just walk into a chaos, and sometimes it's nice, sometimes you have an easy shift, sometimes you don't. Sometimes you have a code blue patient that's crashing on you, or sometimes you have a patient that's bleeding to death. When that wreck happens, so that's what we call it as a wreck. When that wreck happens on your shift, you know what? You take care of that wreck, you find the detour, and once you take care of the wreck, fix the problem, and you need to get back to track and then complete your shift and move on. And that is so important for a new nurse, because if you see a patient that died or something were to happen, got intubated, or something that did not go well, as a new nurse, you might be just caught in that phase for a long time, and you forget and you get delayed on finishing your notes, on doing the documentation, or even progressing or completing that assignment. You stay back after the shift for 2 hours because you're trying to catch up, because you were caught in that wreck for a long time. And we don't want that to happen. So we want you to take care of that wreck, code blue, whatever it is. Once it's done, you need to go back, finish your plan of care, do the education, give medications, complete your notes, and you log off and you clock out and you're done for the shift. So if you do this, you're not going to end up in, you're not going to have burnout. If you don't, you might eventually, at one point, you will feel the burnout. And this is the ICU track. Our ICU, I talk about ICU, but there are other disciplines and it's different for other disciplines. For ICU, what we do is a blended nursing blended training that we give. We have this called ECHO modules. So they get to work on the ECHO modules. It's a self-paced modules that has all the theory stuff, didactic portion. We don't teach every single one of them. So it's really neat, and they get paid for doing the modules. So the first week when they get hired, a new nurse guy get hired, we do 40 hours of training. That's a new hire week, meaning it's an employee requirement. Things that the hospital or organization wants, you do complete that new hire orientation. Residents, if you're a resident, meaning new nurse, you get 2 weeks of 5 8-hour shifts. And during this week, you get to do the skills. You might start with some looping. We have a lot of classes from experts from other fields that's going to talk. It's really classroom 8-hour shift. 8 to 4:30 is a shift from Monday to Friday. And again, we have planned the residency week 1 and week 2, which is really neat to get all important stuff taught to you. And then clinical week 1, which is a clinical orientation, starts after these 3 weeks. And in this, we do 24 hours precepted time. That means 2 12-hour shifts. And then you do 7-hour education days, which are Mondays and Tuesdays. And here you do that modules. You sit in the computer and work on the modules, and here you're going to have a lot of critical care classes. So that's your education time for 2 days. And we do this for ICU. The clinical orientations are for 14 weeks. No, we actually increased it to 16. So an ICU new nurse will do 16 weeks of clinical orientation with the preceptor, and that does not count the 3 weeks of residency or the new hires. And this is just an example, so you know what we do. And our residency is for a year. So once they complete the 16 weeks, every week and every fourth week, they have to meet with the manager and educator. I round on them every week. I kind of look at the gaps, and it's case by case, meaning it's 16 weeks for every person. But if there is a nurse that's really struggling and not up to the track, then we will extend that orientation, and we will do separate goal planning and progress for that person. And after this clinical orientation, the preceptor, they get to choose a mentor for the next 9 months who are going to be the support person for them. With mentors, they can discuss anything. So here, new hire skills day. Some of the skills, I think I have a picture what kind of skills that we do. We do ACLS checkoff. That we do for nurses just to get the hands-on and practice. Plus they get to do mega course modules. This is like 72 hours of ICU curriculum modules. A med-surg nurse has a different med-surg curriculum, and so does an IMC or step-down nurse. So AD has something different. So it's different for different specialties. A med-surg nurse would get 12 weeks, whereas an ICU would get 16 weeks. Classes, we have clinical ClinDoc, which is for 6 hours, and then you have the EKG classes that we do. There's several other classes that you can see how much class that we do and give that in-person training. Some of these classes will have case studies. We have also done games. I don't know how many of you are on Facebook or Instagram. What is our attention span nowadays? It's 30 seconds. So that's why you see reels for 30 seconds to 90 seconds, because anything after that, people don't pay attention. So we do a lot of gamification that we introduce in our class. So in between, some students, our nurses don't get tired, or to improve the attention span, we have something different for every single class. We have case studies, we have simulations, we have escape rooms and stuff like that. And then here, they also loop with other people, like departments. ICU would go to ED to see what the ED workflow is. They work with the telemetry just to see and feel their shoes and their workflow. We do monthly debriefing for all the people, every single nurse that we have, residents that we have, and also the fellows. That's the evidence-based practice project. And these are the skills which we do. This is not considering new orientation skill, because every employee will get certain skills as a new employee. But then this is for, in addition to it, we have the nurse resident skills, because we feel that these are high risk and they always struggle at the bedside. So we want to do those skills, some hands-on with the mannequin or simulation. They have to do written demonstration with the mannequins. They have to put a Foley catheter on a mannequin, and we teach that. Even though they get the training from the academic side, we teach them our way, our method, our process for all of those things first, before we let them have hands-on on the patient. I think I'm done. So in summary, practical application, right? So you have seen that we do clinical rotation, we do simulation, we incorporate almost every other strategy, and we also meet the learner's need. So our program, the way it works is not every nurse learns the same way. each person has their own pace and they learn differently. And if you know the learner, some learners are auditory, some learners are visual, some are tactile, they want to feel it, kinesthetic learners. So there are different kinds of learners. So we kind of figure it out, like we do a test to see what they are, and we try to match it. And we also tailor the training according to their needs. So, in summary, practical strategies prepare nurses for real world nursing and effective in closing gaps between theory and practice. It does foster critical thinking, clinical reasoning, and confidence. And residency programs are great because it does provide and promote that safe and quality care. Obviously, it reduces attrition. People are very happy when you have that good training and good environment and supportive culture, just culture from the people. Then we are more of a family than co-workers. Blend methods for the most significant impact and incorporate multiple strategies. One size doesn't fit, one method does not fit all. So you have to use multiple strategies to get that success. All right, so those are my references. Any questions? It's so hard on a virtual. I'm so sorry if I took a little bit of time. I will share my number. I'll put it in the chat. Put it on the chat. If you have any questions, please reach out to me. So, thank you. Hopefully that was very useful. So you get to see what we do for a new nurse. I can't speak to what they do in India, but at least you get a bite of what we do here. So thank you. And once again, I thank for this opportunity. And thank everyone. And thank you for listening.
Thank you, ma'am, for your enlightening presentation on practical application strategies in nursing education. Your insight and expertise have provided us with valuable key takeaway to enhance the nursing education. Your session was sparked interesting discussions and ideas. Once again, thank you, ma'am, for sharing your knowledge and time and experience with us. We appreciate your time and efforts in making this session informative and engaging. Thank you so much, ma'am.
Thank you.
To ensure we remain refreshed and energized for the sessions ahead, we will now take a short tea break. For the participants, refreshment has been arranged beside the virtual room. Thank you.